I'm an emergency room physician, and I treat all my patients the exact same. That's what just about any healthcare provider will tell you. And yet we find across the entire spectrum of healthcare that this is not the case. Let's focus in on the pre-hospital or EMS environment. This is with a paramedic or an EMT, anytime before you arrive at the hospital. It can be in the back of an ambulance. It might be in your living room. It could be on a street corner. In those settings, we find that women in cardiac arrest are less likely to receive critical interventions, epinephrine, airway support, electrical shocks, as compared to men. Low-income patients are less likely to have their hearts restarted after they stop beating. Hispanic patients are less likely to have their stroke symptoms recognized. Older patients have longer time on scene, a bad thing, after a traumatic event. And African American patients are less likely to have their pain appropriately treated. And we have the data to prove all of this. So how do we know this? Why is this, and what can we do about it? How can I take my paramedics and EMTs from a state of, I believe I treat everyone the same, I don't need to learn about equity, to a state of disparities exist, particularly in healthcare. Equity matters to my patients, equity matters to my community, and equity matters to me. In 2019, Milwaukee County, population of about 1 million in southeastern Wisconsin in the central United States, was the first in the nation to declare racism a public health crisis. Now, with that came a stepwise approach to addressing and enhancing equity. Now, the first step is understanding that inequities exist, especially in healthcare. The women not receiving cardiac arrest care, the Hispanic patients not having their strokes recognized, and the African American patients not receiving pain control. Now, the second step is understanding what equity is. Now, equity is not equality. This is often confused. Equality is treating everyone the same. Equity is understanding that disparities exist at the individual level, the community level, and addressing them in a targeted manner. It's also not justice. Justice is the goal, but equity is the means. Let's give an example. If you have a community and you spread vaccination sites evenly through that community, that is what equality looks like. But if you also do smaller scale vaccination sites in grocery stores, in churches, in barbershops, in the highest need, most vulnerable communities, that's what equity looks like. So once we have this common understanding of inequities and equity, we move to step 3, which is the data. In my EMS system in Milwaukee County, we have about 120,000 patient encounters a year. We're one of the largest systems in the country. On January 31st of 2020, in our electronic patient care record, we only recorded race and ethnicity about 50% of the time. The next day, February 1st of 2020, we recorded it 100% of the time. How did we make that change? I wish I could say it was education and training and understanding of the importance of data, but really it was just flipping a switch. We made that field in the patient care record mandatory. But that made all the difference. It gave us a window into understanding how we treat patients equitably, or inequitably, as the case may be, by race and ethnicity, as well as age, gender, and so forth. But that data, that knowledge, can be groundbreaking in understanding and improving health outcomes in the community. Which brings us to fourth, using that data to educate and to inform. In Milwaukee County, we developed something called the EVE model. It stands for Evaluating, Vulnerability, and Equity. It's a simple 4-quadrant design you see on the left here. Along the bottom, moving left to right, is vulnerability. Now, this is from the U.S. Center for Disease Control and Prevention's Social Vulnerability Index, or SVI. It's a category based on 15 census-level variables, things like access to transportation, employment status, income level. And it gives you, your community, a vulnerability score, 0 to 1. More vulnerable is on the right. And going up and down on that vertical axis can be any number of variables, but in this case, we were focusing on vaccines, so we chose vaccination rate. The higher up you are, the more vaccinated your community. Now you can take this 4-quadrant design, and as you see on the right, you can apply it to a map. And you color code those census tracts. Now focus in on the orange. That's what we did. And for those orange census tracts, we did targeted messaging. We knocked on more doors. We vaccinated folks who were homebound. And we set up those small-scale vaccination sites. We could have made that V stand for vaccine, but we resisted that because we knew this could do so much more, and it has. We've applied this to gun violence. We're applying this to opioid use, and we get similar orange census tracts to focus our messaging, to focus our resources, and to target our interventions. Now, this is one example, but the data we have and are gathering in our community continues to inform the equity information behind the disparities that exist. Now, you may not work in healthcare, but whether you work in the back of an ambulance, or an office, or a factory, or anywhere else, you can improve equity if you have the data to inform and the will to make change. So modify your training to educate on disparities. Leverage your data to inform on inequities, and change your policies to enhance equity. And by doing so, you can improve the health and the wellness of those with whom you work, those you serve, and your broader community.